Okay. It's recording, I believe.
All
Okay.
right. And can you see this slide of CGI
Yes.
woman walking down the
Yes.
building
Yes.
hall? It actually does look like that now that they built it, but yeah, these aren't real people. Um, but yes, I'm happy to introduce myself. Thank you so much, Olga, for kindly extending this invite. My name is Chris Warren. I have had the privilege of working in the food allergy, and I kind of started in as community-based asthma research and quickly found my way into food allergy research as a young, enthusiastic kind of project coordinator back in 2011. And quickly, when I was hired by Ruchi Gupta at Northwestern, when she was kind of first starting her research group there, and quickly discovered that, holy cow, do we have a lot to learn about the public health burden of food allergy and how to go about trying to address it. And so that's kind of what I have been doing over the past 12 to 13 years. In the interim, I went and got my doctorate in health behavior research and population health at USC. I did a postdoc at Stanford in kind of like data science and translational immunology, which is a fancy way of saying COVID research, because I was there right when COVID started and everybody pivoted to that. And then was hired back to Northwestern about like 2.5 years ago as junior faculty, primarily in the Center for Food Allergy and Asthma Research, where I'm the director of population health research. But I also have an appointment in the Department of Preventive Medicine's Division of Epidemiology. So unlike you all or most of you all, I am not a clinician. I see the patients when they appear in my database and occasionally when I, talk to them in like cognitive interviews and stuff. So I greatly respect the work you all do and just trying to make sense of things sort of like at a couple levels up, in terms of the taking the bird's eye view of the food allergy pandemic and trying to wrap our heads around what makes sense in terms of next steps. So since Olga generously gave me no direction about what to talk about, I thought I would just kind of share a little kind of a sampler of what I've been working on the past like decade, and then also just kind of a broad survey of the field with an eye towards some emerging modalities of food allergy prevention, or at least some like arenas where we might want to start thinking about intervening. So I hope this is useful. If it's not, feel free to tell me or leave, or ask questions. Otherwise, I've got way more than enough slides, and I will just kind of keep on blasting through. So is that we good to start? Cool. Yeah. So just to set the scene, you all know there's lots of different kinds of food allergies. I am primarily going to focus on those of the IgE mediated persuasion. And you all again are clinically trained and know your way around the immune system a little bit. But just I think it is important to acknowledge that when you're trying to understand the burden of food allergy, the diagnosis of food allergy, the treatment of food allergy, the prevention of food allergy, you got to remember that it doesn't just first appear as the clinical manifestation of symptoms. The first step to developing a clinical food allergy is that sensitization to the antigen phase. And so when we think about how do we prevent patients from experiencing burden of disease, you can start by trying to prevent the sensitization in the first place, or develop strategies to try to understand like why that sensitization happens. But then there's a lot of rubber and road in between sensitization and when the immune system manifests as clinically reactive against an allergen. And so I just think those two things are kind of occasionally conflated. And I know, a lot of our clinical tests are tests of sensitization and not actual clinical allergy. And I just think it's important to make that distinction on the front end. And so you all know what IgE-mediated reactions look like when you see them. But what's important from my perspective is that rates of anaphylaxis have really been on the rise. Not just sort of anecdotally, but empirically over the past 25 years, and they don't appear to be slowing down. And this is just in the U.S., but in much of the rest of the world, particularly kind of major urban centers. Like it seems like everybody's catching up to us, and maybe we're catching up to Australia, who seem to be kind of the early leaders in IgE mediated food allergy, like back in the early 2000s. This is a lot of the figures in food allergy go from bottom left to upper right in terms of increasing burden. But at the same time, while all these people are affected, it isn't, and all these people being, kids and adults, I think it is important to contextualize food allergy, appropriately, where mercifully fatality related to food allergy are still very, very rare. While they get a lot of attention as they deserve to, it is fatality is while it's often on the mind of patients and their families and their loved ones, it is an extremely rare outcome, about equivalent, some have estimated, to your odds of being struck by lightning, on a given day. So that said, I think there's a lot in terms of the mitigating the public health burden of food allergies. I think, yes, one important piece is treating food allergies, desensitizing people to doses of their allergen, blocking IgE, things like that. But I also think a lot of the burden that is actually experienced by patients of food allergy is psychosocial burden, and it's the burden of living your life potentially feeling like you are at risk of a very, very bad outcome at any given moment that you let your guard down. And so I think if we can figure out ways to get patients to sort of have the just right amount of vigilance that allows them to avoid their reaction and kind of stay cool and calm in a situation where they maybe are accidentally exposed, and they can efficaciously treat themselves or treat their child, I think we'll be in a very good place. And we're still trying to figure out how we do that. And at the same time, there's a big psychosocial burden. There's also a huge economic burden of food allergies, like not just on the healthcare system, but on families who are trying to manage this day to day by purchasing sort of allergen-free versions of foods, which cost of foods has gone up a lot all over the place. The cost of the allergen-free kind of equivalent of a lot of foods has gone up even more, placing a lot of burden on families. And then obviously the impact on the healthcare system is tremendous, with all of these patients showing up in the ED, requiring medications, and now with all of these emerging treatments on the horizon, which are not cheap. That is also only going to continue to grow the burden of food allergy, making its treatment and management like a very, very important issue, for just like our society in general, as well as like the individual. So this is a study we did about 10 years ago, estimating the total annual indirect and direct costs of food allergy to be about $25 billion a year, which worked out at the time to just over $4,000 a year per child. But that estimate was just for pediatric allergy. And that was before any treatments were available. And so we're in the process of re-administering that survey to an even bigger sample of kids and of families, but looking at adult and pediatric estimates. So stay tuned for that. And we'll also assess the quality of life and psychosocial burden when we do that later this year. So hopefully that'll be informative. When we look at, as I said, going from bottom left to upper right, we've known for a while that the prevalence of food allergy is going up. And this is shown, via primarily large surveys, like the federally administered surveys through like CDC, like the NHANES, the National Health Interview Survey, which, while they are certainly far from perfect, do show a general trend of increasing, prevalence over time, no matter how you slice it. But it's very hard to estimate the burden of food allergy for a lot of reasons. And so over the last 10 years, we've been trying to figure out, like, because unfortunately the way that the CDC, going back to this slide for a second, has measured food allergy is very imperfect. It's asking people, just stuff like, during the past 12 months, has the sample child had any kind of food or digestive allergy? Like, yes or no. Okay, that's helpful, but also, there's a lot of people who think they have allergies who don't. There's a lot of people who may be allergic but think it's something else, and so it's without getting these patients in front of you, it's hard to really know. Um, but it's better than nothing. And that's kind of was our starting point when we tried to do one better on the CDC to really try to understand like what is the actual current burden of IgE mediated food allergy in the US. And this was something we first started trying to do about 11 years ago. And you might think like back in the day when everyone had landlines and you wanted to try to sample a representative population of Americans, it was plausible that you could just randomly pick numbers out of the phone book and call them. And most of the time, someone would pick up, and give you reasonably accurate, truthful information because they wouldn't be that skeptical that you're, trying to sell it to some third party or whatever. Um, those days are long behind us. Nobody's got landlines. Nobody's picking up their phone to unknown numbers. A lot of people are skeptical of giving anything remotely resembling like personal health information to anybody they don't, personally know. And so that's no longer tenable. And so we've had to kind of innovate new methods in trying to do these national prevalence studies of food allergy. And so one way we've tried to do this is through leveraging best-in-class survey research panels that are recruited using the same methods that the census uses, where they do randomly select like post office deliverable addresses, across the whole country, and then try really, really, really hard to get everyone who is randomly selected to enroll in these like nationally representative market research panels, including, mailing stuff to them, mailing them money unconditionally, calling them, texting them, showing up at their house, being like, please, 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 just answer, questions, not about food allergy, but just about kind of stuff in general. And so we decided that we could maybe leverage that for the study of food allergy. And we were successful in doing that. And the nice thing about working with these kind of nationally representative panels is that they're enrolled in ways that we are confident are representative of the general population. And then when you administer surveys to those panels, you've got a lot of information, not just about the people who do respond to your survey, but you have a lot of information about the people who don't respond to your survey because they've already provided a ton of information to the folks who are running the survey panel. So we can adjust for all that in our statistical analyses and get much better estimates. And so we've come up with some innovative ways to combine those with other sources of sampling that I won't get into. But that is kind of the first big challenge that we encounter is how do you get a representative sample in trying to measure these things? And that's one solution that we've come up with. Of course, the other big problem with trying to measure food allergy, as I've alluded to, and well, is how do you make sure somebody's got a food allergy who's telling you they have a food allergy if you don't get them in front of you and you can't do the skin prick testing and you can't do the food challenge. So one strategy that we have done is try really hard to develop kind of algorithmic approaches to estimation of different, like basically we create different case definitions for food allergy based off of taking patients' history sort of through these survey algorithms. And so acknowledging that, there are a lot of people who report allergies that don't have them because they have other conditions. And so we try our best to, like, based off of what people report in terms of their reaction symptom history, rule out stuff that's more consistent with like pollen food allergy syndrome, oral allergy syndrome, lactose intolerance, scromboid poisoning, things like that. And then arrive at this estimate of like, okay, you've got your people who report your food allergy, you've got your people who meet this kind of like convincing definition where we're pretty sure that's consistent with a food allergy. And then you've got your people of that subset who have actually then reported that their food allergy was diagnosed by a physician and that they had some sort of testing done. And so we kind of end up with three definitions of people. There's your reported, your convincing, and your physician confirmed. And we think the truth is probably closer to the convincing than either of the other two. And we have looked at this on a smaller scales. Like, when I was at Stanford, we like kind of ran this algorithm with everyone who's coming in and doing screening for our clinical trials, and found that it actually worked quite well. And we have a big grant to NIAID right now that is gonna, if it's funded, we'll be able to really redo our big national prevalence survey and include clinical validation to come up with like a really, really rock solid algorithm that's clinically confirmed. And so, you know, June 4th, send very good vibes to NIH if you want that to happen, because that's when they're talking about it. And so we did this survey about, I guess we did one survey, just of kids in 2011 using that approach. And then we did another one, about 6 years later, which is now, many moons ago in 2015, 2016, and estimated that about 1 in 10 adults do have meet the convincing definition of food allergy for at least one food allergy, and about 1 in 13 children meet that convincing definition of food allergy for a prevalence rate kind of between 7 and 8% of kids. And that estimate's consistent with what we had estimated back in 2011. When we did that survey in 2016, we also were able to get some limited insights into prevalence of these other non-IgE or kind of mixed presentation food allergies, where we estimated that about like 1 in 200 US kids appear to have a lifetime history of FPIES, which was kind of shocking at the time. But now there have been on data from some like a cohort in Massachusetts that actually reported like almost 1% of the kids in the cohort had FPIES. And other data have sort of provided estimates around there since then. So it could, while again, the survey was limited in terms of its ability to really zero in on whether or not these kids truly have FPIES, like the estimate appears pretty consistent with what we're seeing in much better characterized samples. And we have another big grant that's under review at NIH, which would basically do a massive survey and claims analysis to really understand the current burden of FPIES.
Chris, can I interrupt for a second? I actually have a
Always.
question. Did you have the same algorithm when you went into looking into FPIES and AOE in that
No,
survey?
no, it
No.
was much more limited. Yeah, it relied on having a physician diagnosis of those conditions. And then we knew the trigger foods, but we couldn't really zero in to the kind of like delayed manifestation of the vomiting or things like that.
Okay, thank you.
Um, but when we get funded to do this big new prevalence study, we will have an extraordinarily detailed ability to really zoom in and understand all the different kind of subtypes and stuff. So yeah, so from that, we got all these sets of estimates, and I won't belabor these because now they're kind of ancient history. But it does show you the kind of chasm between the people who report they have a food allergy, the people who you know plausibly do have these food allergies, and the people who actually have a physician confirmation of these allergies. And so there, and I think when you think about like what's the real burden of food allergy, a lot of people like to say, oh well, if you don't have a double-blind placebo-controlled like food challenge confirmed allergy, like, oh, that doesn't really count. But on the flip side, if you're living your life every day as if you're going to die from eating the wrong food, like that's a burden, and that matters also. And so these epidemiologic studies kind of try, when they're done well, they kind of provide insights sort of at all levels. Like what do we really think is truly, happening with these immune mediated conditions, and then what do we, the lowest hanging fruit is ruling out allergy from public in the people who really don't have it. Like honestly, I think some of our best public health interventions could be just like, hey, no, you're good. Like you don't have this allergy. But it, for all sorts of reasons you're all familiar with, it's more challenging than it appears. And so another big contribution of this study was kind of highlighting that sesame allergy does appear to be on the rise in the U.S. I mean, it's been a global concern for a long time, like particularly in the Middle East and other parts of the world where they just like eat more sesame containing products regularly. But that was one big contribution of this study, and it just really highlights the the exceptional burden of shellfish allergy also in adults, relative to kids, where they've got more, peanut and milk and tree nut allergy, whereas adults, tend to have more seafood dominant phenotypes. But still, a heck of a lot of adults appear to be allergic to milk, which is something that for a while was kind of thought that most kids tend to outgrow. Although importantly, we did distinguish between like allergy to baked and unbaked milk and egg, and 2/3 to 3/4 of folks who were milk or egg allergic could reported like being able to consume baked forms of those. But I know that's another area where you could really improve a patient's quality of life, is if you go from avoiding all milk and egg to only avoiding unbaked versions of those foods. You can open up a whole world of delicious things. So, oh yeah, this is just making the point that these data actually really helped inform the FDA's addition of sesame to the new list of allergens that require labeling. And also, because we are able to administer these surveys to such a large number, we got data for almost 80,000 individuals. And so when you have that many people, and we had half the sample was kids, half the sample was adults. And so we had a lot of granularity in our pediatric sample. And so you can kind of get some insights into the natural history of these conditions through childhood, where you see here milk, it kind of comes on early and then tends to sort of by later childhood, adolescence, is often outgrown. Same thing with egg, whereas things like shellfish tend to just sort of keep on ramping up and are more persistent over time. And thankfully, of the few studies that have employed kind of challenge confirmed outcomes to try to assess prevalence, none of which are in the US, but there are other parts of the world, they have generally found estimates like pretty similar to some of these estimates that we got at through survey. I mean, there are obviously some discrepancies too, but the challenge is getting folks to, when you're doing an epidemiologic study, you want to get a representative sample, and often even it doesn't matter how hard you try, there's going to be some attrition when you force people to come into the clinic, like to do double-blind placebo-controlled food challenges, just because you like want them to for epidemiologic reasons, and it's not like an urgent health priority or viewed as an urgent priority for the patient. So that's a challenge we're continuing to deal with, and we've got some ideas of how to surmount that. But that's definitely an area where we're still running into challenges. And then another big finding is obviously that a lot of adults are coming down with adult onset food allergies. And while that was kind of anecdotally reported, and people who experience them know, it wasn't sort of like widely acknowledged until we showed just very clear data that these folks are developing allergies in adulthood. And sometimes it's their first allergy they've ever had. Often it's they've had other allergies as kids, and then they go on and develop shellfish allergy as adults. But in any event, it's an important thing to understand, because it's potentially a different mechanism than these people who you get, these are often people who've consumed the food their whole life and then lose tolerance, as opposed to like not gaining tolerance in the first place. And so I think it'll be important to understand kind of both sides of that. And another thing we were able to do with our big surveys is try to understand like kind of population level trends in food allergy management. And we see this is looking at different ages and the rates of reporting that they have a current epinephrine auto-injector prescription. And we see particularly among adults, these rates are quite low. And we know in kids, and it's obviously one thing to have a prescription. It's another thing to carry it, and have it accessible. But if you don't even have it in the first place, while there's some stock epi around, and maybe you got friends and family who sometimes have epinephrine available, it's definitely not optimal to be going around with no potentially life-saving medication. So the other thing that we have really started to understand more is these like multi-food allergic phenotypes. And this has become particularly salient recently with the whole omalizumab, being approved, with the idea being like, probably going to really help the folks who are allergic to lots of allergies in very severe ways. But it wasn't really appreciated, I don't think, until the last like 5 to 10 years, that when you talk about people with food allergy, I mean, between a third to a half of everyone with food allergy actually has food allergies, and it doesn't matter how you slice it. You've got it's not a rare phenomenon, and the more, and that's the case in kids, that's the case in adults, and adults are a little more likely, if they have food allergy, to be multi-food allergic. But it matters because the more allergies you have, the more likely you are to utilize healthcare related to your food allergy, the more likely you are to have severe reactions, the more likely you are to have reported that you used epinephrine, and while it's not shown here, the more likely you are to have other atopic comorbidities. So these folks with multi-food allergy, and eczema and asthma and allergic rhinitis, these are folks who are highly burdened by allergy, and do merit kind of like particular attention, clinically, because they just bear such a brunt of the disease. And on the flip side, when I was, especially when I was first starting doing food allergy research, it was basically everyone was just doing peanut allergy research, and all the treatments were for peanut allergy. And it's like, it's very important. Obviously, a lot of people have peanut allergy, and it's burdensome. But the number of people walking around with just a peanut allergy is a very small proportion of the total food allergic population. And that's something I don't think is still very well appreciated by a lot of people who don't like deal with this regularly. So just accommodating peanut is not really going to make that big a difference, from a public health standpoint in terms of the whole affected population. So I don't know if maybe this would be a good time to stop, ask for any questions, or is this at all what you signed up for?
This is fascinating. So I did put in the chat if you guys want to put your questions in the chat, or you can unmute. Or should we wait till the end?
But yeah, fine.
All right. Thank you.
So another big area, that I've always been interested in, and has always sort of been in the background of food allergy research, although it hasn't really come to the fore until pretty recently, is just the tremendous apparent, health inequities and disparities that are clearly happening in food allergy, and we've known have been the case in other atopic conditions, like asthma, atopic dermatitis, which have disproportionately impacted, non-white, lower income folks, particularly those living in cities, for a while now, particularly African Americans. And from the very first epidemiologic studies of food allergy in the US, like this conducted at Sinai by like Scott Shisher and colleagues back in 2004, it was very clear that particular rates of seafood allergy were much, much higher among Black kids here than adults. And it was clear in the NHANES data back in 2007, 2010. It was clear, when they looked at the serologic data from NHANES, because NHANES is nice because it asks both about diet, and then on a subsample they get the blood samples, and you can run those. And so they need to do it again. We're trying to get them to do another big, allergy module, but showed that sensitization, particularly to peanut and shrimp, were much higher among Black and Hispanic kids than white and other folks. But I feel like when I first started in this field, like 10, 15, 12 years ago, it was still kind of viewed as like this condition that predominantly impacted more affluent like families from the suburbs. And so I just feel like it's a narrative that I still encounter, like when I talk to people, and it's like, no, the data are so crystal clear that health disparities are such an important issue in this field, particularly due to a lot of things I'm going to get into here in a moment. Another thing, we talk about fatal food anaphylaxis being rare. It's rare across the board, but if you break it down by sex and race, you can see that here, the only increases that have been seen, of kind of longitudinally when you look at trends in fatal food anaphylaxis have occurred among, African American boys. And rates are threefold higher of anaphylaxis of fatal anaphylaxis among African American boys and twice as high among African American girls. And so obviously that's the most severe possible outcome, and you see pretty apparent disparities there. And so based on those data, we at Northwestern kind of teamed up with some colleagues at Rush and Cincinnati Children's to try to really develop a cohort of kids to try to better understand like the natural history of food allergy in these different populations, and why are we seeing these different outcomes? Do they have different phenotypes? Is it managed? Is it being managed differently? Are there a lot of other factors at play? And so we started back in 2017 by starting this cohort in Chicago and Cincinnati of Black, non-Hispanic Black, Hispanic, and non-Hispanic white children who were diagnosed at the allergy clinics associated with our institutions. And lo and behold, we did see pretty substantial differences in rates of food-induced anaphylaxis, rates of ED visits, rates of like comorbid eczema, asthma among non-Hispanic Blacks, and then notably like just average duration of specialist care was indicative of kind of people maybe getting a visit or two in and then kind of dropping off and not getting that continuity of care that is needed. And we found the same thing when we looked at our national prevalence data, that the prevalence of food allergy, no matter how you slice it, was lowest in non-Hispanic white and non-Hispanic Asian populations, and considerably higher in non-Hispanic Black and Hispanic folks. And you see that not just overall, but in basically every single specific food allergy, particularly in shellfish, milk, and peanut, but also pretty much everything else except for like soy, wheat, and sesame. And then you also, in our national prevalence data, see the differences in emergency department visits as well, which is something we see across the board. And so yeah, just to put a pin on it, the data are overwhelmingly clear that there are clear disparities in food allergy outcomes and management. And we've got, I won't get into it, but we have this when we started that cohort, the forward cohort, we have since enrolled like 1,300 patients and are continuing to follow this very large, diverse cohort, kind of hopefully perpetually moving forward. And we've learned a lot. And I don't know, can you see the? Oh, I guess I removed them from my presentation, but you can still see them. So I won't get into this, but basically we have this big cohort of right now almost 1,400 parent-child dyads, and we're following them now. The oldest kids are becoming adults and enrolling in the study as adults. We see them every year in clinic. We do biospecimen collection. They do quarterly surveys. Once they turn 10, we survey the kids and the adults about like a whole range of different psychosocial factors, behavioral factors, environmental factors, things like that, and have really started to understand a little more about some of the mechanisms and endotypic differences in like why these food allergies manifest themselves differently across folks growing up in different environments, folks who are like racialized in different ways, including one thing that is kind of interesting and somewhat disgusting, since it's dinner time for many of us, but just this idea that you see very high rates, obviously, of seafood allergy in non-Hispanic Black and folks, especially if you grow up in urban, like highly urban, like inner city environments, where we know rates of dust, like sensitization to dust mite, house dust mites, and cockroaches is really elevated. And when you look, you can see how the folks who are sensitized to house dust mite and cockroach are much more likely to then go on to develop sensitization and then allergy to shellfish. And there's a very clear mechanism why this could be happening, which is that you're sensitized to this tropomyosin, which is like a protein that, is in the muscles of these little cockroaches and dust mites. And unfortunately, or fortunately, it's shared in shrimp and a lot of crustaceans and other, seafood allergens. And so often we think folks are first developing that sensitization and allergy to the tropomyosin in the dust mites or in the cockroaches, and then the immune system is basically, when it sees shrimp, it just kind of sees that tropomyosin again. It says, all right, go, this is a baddie. Let's go get them. And that's how, we see this sort of like later manifestation of shellfish and finfish allergy, in adolescence and particularly in adults. And we think it's particularly likely, because shrimp allergy is by far the most common adult onset allergy. And we think that's probably due to this sort of slow, steady, increased sensitization to tropomyosin in combination with sort of like probably sporadic dietary exposure, because most people aren't eating shellfish like this every day. They might eat a bunch of it one time and then wait a long time in between. And we know the longer you wait, in between exposure, the more likely you are to develop an allergy to it. And so we, I won't get into this. We published a lot off of Forward. And so kind of like shifting gears a little bit and zooming out, because this is really what I'm most interested in is, clearly when I grew up, my 5th birthday, the theme was edible Play-Doh, and my mom made a bunch of Play-Doh out of like cornstarch and peanut butter, and me and all my friends are like rubbing it all over ourselves and making stuff out of this edible Play-Doh. Ate probably like a pound of it. No one was worried about food allergies. I'm not that old. And but now it's clearly, there's clearly something going on. Something has changed, and it's not our genes. So what the heck? And this slide shows that like when you really look at all the different kind of, it's not just like the rise of food allergy is not the same as the rise of all allergy. It's a more recent thing, and it probably has a discrete cause, just like kind of the rises in these other different allergic manifestations have had, which started earlier, and so I think it's helpful to not just consider like the allergy epidemic as like one big thing, even though there's probably a lot of shared determinants, but really try to zoom in, like what's going on with food allergies, because it's clearly come on so fast and so strong. So one thing I think is interesting to think about is, obviously, we evolved over, a long, like billions of years, when you think about like the protoplasm that became our early immune systems. And, one interesting kind of thing to think about is, for 99.9% of our evolutionary history, where we were like hunter-gatherers, and where you were born, and the things that you were exposed to in that first, year and a half of life, and then your prenatal exposures as well, you were probably going to be exposed to every antigen you could plausibly encounter the whole rest of your life, because you would have gone through a couple seasons. Maybe you were nomadic and you went from like a low plain, in the winter where it was milder, up into sort of the foothills or the mountains, like to during the summers. But like you're all the environmental allergens you pretty much probably encountered. Your diet's pretty steady. Even if you're kind of eating different things at different times of year, you're probably immune system is getting exposed to those things during the period in which it evolved to be very sensitive to environmental exposures, and be prone to be tolerant to them, because that's, if something's not actively trying to kill you, your immune system has no reason to really activate and try to expel it, which is what the IgE driven allergic response does. And we know that the whole reason we have IgE is to handle these kind of chronic parasitic infestations that accompanied us for so long, in our history, up until not very long ago, a matter of decades, when we kind of eradicated all the hookworm and roundworm and stuff. And during that time, we've seen like a massive increase in food allergy. But I just think that's sort of an interesting observation. Obviously, that's not the whole story. And the other story is these things on the right have all have also happened sort of in tandem with that. We've had big changes in our environment. We've had changes in our diets. We've had, all of which impact our microbiomes, and we are moving around the world in ways where our genetic ancestry maybe prepared us for one environment, and then we move halfway across the world, and maybe our immune systems and our other evolved traits are not so well matched, for the exposures that are a little more common in those areas. And so we see epidemiologically, kids nowadays, zooming into the present or thereabouts, well, the kids who eat, you're exposed to more different foods earlier in life, you're less likely to develop food allergies. It doesn't matter how you cut it. Work by my colleague Karina Venter and others kind of on the Isle of Wight have shown this fairly compellingly in their Isle of Wight birth cohort. The more foods you feed your kid by 6 months, or number of different types of allergenic foods by 12 months, the less likely that kid is to have food allergy during the first 10 years of life. Other studies across this kind of Central and Europe have shown very, very similar findings. So that's an interesting piece of evidence suggesting that the more, and because when you're eating more, you're introducing your child to more foods, you're inherently kind of like introducing them to more foods that they're probably also likely to encounter like later in life. But the real, the elephant in the room when you talk about, the rise of allergies, folks always say, hygiene hypothesis, we're too clean, it's these infections. And while it is true, that there's been this epidemiologic observation that, as we've been able to effectively control a lot of these infectious diseases, we see these spikes in chronic, inflammation and allergic conditions, including food allergy. That's probably not the whole story. So we've since done a lot more kind of careful interrogation of the hygiene hypothesis, where you look at, well, really is it, are kids who get more, early viral infections, like more likely to, to have food allergies? And, we think that, that's been pretty carefully interrogated, and it's just not the case. Rather, there's been sort of a move towards this idea that, it's less the early exposure to kind of dirty or infectious disease environments, which when we were in bands of 100 or dozens of hunter-gatherers, like it's very unlikely that we would have evolved an immune system that required input from like an infectious disease, because if you're only in a cave with like 10 other people and one of you guys gets the measles, like everybody's getting the measles, and you're probably not going to fare so well as a tribe or a band. But rather it's this mechanism of, we co-evolve with all these commensal parasites and bacteria that played a beneficial role in our human evolution, insofar as they provided like predictable regulatory inputs into our immune system. So we know that the more microbial diversity that kids are exposed to early in life, I say we know, there's evidence to suggest that the more microbially diverse your environment is when you're little, the less likely you are to develop some of these allergic diseases, inflammatory conditions. I'm very biased as a dog owner, but I was very interested in this, and this is my dog Sergio, by the way. Very interested in this study, which was off of the EAT study, which is a big interventional study of early food introduction for primary prevention of food allergy, showing that the kids who had a dog at 3 months of age, I mean, holy moly, what other that's better than the LEAP study's effect on peanut allergy is just having a dog in the house. That's a massive drop in food allergy prevalence. Even after adjusting for a number of things that would likely confound that association. So that's an interesting observation, and it's not just food allergy; it's also associated with a dramatic drop in sensitization to house dust mites. The idea being that what a dog does, or at least my dog, and I think many other people's dogs, is they bridge that gap between the outdoors and the indoors. Even if you wipe their paws, they're still bringing in a lot of crap from outside, and it's not crap. It's just kind of random stuff from the outside environment. And, you're getting them close. And if you got a little kid like I do, they're at dog level all the time, and they're getting a big dose of that stuff that the dog is bringing in and around, and it doesn't matter how clean you want your house to be, that dog is going to bring in stuff you can't even see. And it really does appear, like from the cohort studies that have really looked at this in a very systematic way, that if you've got a dog that you allow indoors, so you can get those exposures indoors and kind of more regularly in higher doses, your kid's less likely to have food allergies. It's also this case with cats. Um, my apologies to the turtle and hamster people, but it doesn't appear to be as effective. And it's not just effective for food allergy overall, it's effective when they zoom in. And this is a huge cohort study that they've been running in Japan with over like 100,000 kids, very well characterized. And they find it for egg, for milk, for wheat, for soy allergy. They've also looked at this for, in other really big cohorts that are well characterized, like the Health Nuts cohort of about 4,400 kids in Melbourne, Australia, where these folks who have the pets who are allowed inside are really appear to be strongly protective against early onset of food allergies.
Chris, we're about 10 minutes before the hour, so just wanted to see if we have time for some questions at some point.
Yeah. I'll just keep going if no one asks questions. Otherwise, I'm happy to just keep on trucking.
All right, I just wanted to give an opportunity. If anybody has questions, either put them in the chat or unmute or raise your hand so we know that to kind of pause and answer them. Thank you. Go ahead, Chris.
Yeah. And so another kind of parallel, very early intervention, that can make a big difference in terms of the early life microbial exposures of infants is C-section birth. And while it was sort of debated about, is this does this really have a strong effect? Can you like take steps to mitigate the differences between a baby being delivered sort of the way that we evolved to deliver them, sort of through the vaginal canal, where the very first types of microorganisms that are allowed to like seed that pretty otherwise sterile baby as they come out and enter the world are the ones that are disproportionately beneficial and present in the birth canal. Like we think that is probably likely to set that child's microbiome up for more success than this sort of game of roulette of, well, once the baby's delivered to the doctor's hands, like kind of whatever's on the gloves and absent the beneficial sort of colonization of the baby sort of through that delivery process, which takes a little while and makes sure that the baby kind of does get a fair dose of these microbes. And so this slide just shows, there was a recent meta-analysis that showed pretty conclusively that kids who are born via C-section have a significantly increased risk of food allergy. It's not a determination that they're going to have food allergy. It's not an effect anywhere near as strong as the protective effect of dogs, but it is nonetheless something we should consider, and also consider ways that we can maybe of babies born via C-section, approaches we can take knowing that they might be at elevated risk, and particularly of like microbial dysbiosis, and trying to remedy that. And so this is just
we have a question in the chat. I just wanted to turn your attention. So one is from Sarah. She wants to know, what are you most excited about in looking at the food allergy research? And the second question is from Julianne. We'll get to it next.
Yeah, I mean, so for me, I think what I'm excited about selfishly in my own research is we are currently about, I don't know, between a third and a half of the way through a very, and I'll maybe I'll zoom ahead. I think are you all familiar with like the LEAP study and the EAT study, the idea that early introduction is probably beneficial for most infants, and kind of the earlier the better. And the more regular the introduction, the better. We've been running for the past year and a half a very large randomized controlled trial called the CAN-DO trial, looking at the effectiveness of introducing kind of 8 commonly allergenic solids early in, ideally around 4 months of age in to families of kind of at high risk and then at sort of normal risk of food allergy, with the idea of really trying to ensure, because where the EAT study ran into difficulty, it was an awesome study, but LEAP showed that early introduction of 6 grams of peanut was very effective in reducing peanut allergy compared to kids who completely avoided peanut allergy, which like no longer is ethical to do now. And then EAT showed that, if parents actually are successful in introducing these 6 commonly allergenic solids early in life, and keep it up, they can prevent, peanut allergy and egg allergy. But very few parents in the group actually who were randomized to do so actually were successful in feeding their kids those allergens. So we really don't know what would have happened if all of the families who were randomized to do the early intervention actually did it, and which would have given us a heck of a lot more insights into like, well, then what's the minimum dose? Because you probably don't need to do that much and that often and at that early in every kid. Wouldn't it be nice to know what the kind of minimally sufficient dose frequency and timing is to prevent food allergies, so we're not making parents who have enough on their plates like do these crazy regimens? So basically what we're trying to answer with this study called the CAN-DO study is, can we prevent allergy to a bunch of these foods with, kind of lower doses of these food proteins started early? And the way that we're trying to really get, just have our study be successful is by really, really, really trying hard to get the parents to support the parents in introducing the foods. So we are, delivering the foods in the formats that they want directly to their door. They're connected with, we've got nutritionists and dietitians who are coaches assigned to each participant, basically trying to be their best friend, walking them through early introduction, trying to power through like early, because there's a lot of hesitation, a lot of fear around introducing things this early, or when a kid maybe has like a little rash when they introduce. A lot of parents just like shut it down and get scared when, if it's done in a safe and supervised way, you can often, get through that very early manifestation of sort of an adverse response, and then get it in the diet. And we think for those kids, it's probably really beneficial. So we've recruited almost 700 infants into this study. We've been evaluating them at 1 year for food allergy. We're evaluating them at 2 years, and we're evaluating them at 3 years. And in the process, we're learning a heck of a lot about a bunch of other things, because we're, of course,
At
getting
how
a bunch.
many weeks are you starting them? However,
Well, we're enrolling them around 2 months of age, and then we're starting them basically as soon they tell us, as soon as they introduce some solid, we then, and that's going well, when they're developmentally ready to eat, we then encourage them to start feeding these seed foods, what we call them, in like a staged format. So they start with yogurt, and then go on to kind of through the rest of the foods.
oh, I see. So it's not the one that already said go where you put some amounts into actual milk. You don't,
Well, so
formula.
that's an option. We do give everyone the option of powdered forms, and we give the older kids options of puffs, but we really think it's important to try, because there's something to the way that we evolved to eat these foods, like in the matrix of the food, the actual food. And I do think it's important that we encourage kids to eat like food that our ancestors would have identified as food, like
Right.
whole foods. And so we really do try to get them to eat them like as yogurt, like as like tahini, things like that. But we do offer the powders, and the parents can use those as well if they want. And we have like
Mhm.
puffs too. So
Thank you. So we have a couple more things here. So Julianne just commented that one of her born by C-section had no allergies at all. My two born naturally, as she says, and have food allergy, asthma, and allergic rhinitis. So just a comment. And then we do have a question. Do the benefits to pet exposure, C-section birth, etc., also show up in, Black population in light of the disparity? So I guess, did you go as granular as breaking it down by ethnic backgrounds?
yeah, well, so to the point, and I actually gave Naya just had their first ever workshop explicitly on like food allergy and atopic dermatitis disparities. And so I actually gave a presentation trying to diving into what do we know about prevention in all these priority populations. And I did dive into a lot of that data. I don't have it in this slide, but basically the one other explanation, one explanation for why we see these disparities is like big systematic differences in exposure to these risk factors and also, to the preventive factors. So, we know, yeah, Black babies are much more likely to be delivered via C-section. There are, what was the other one? Oh yeah, pet exposure. Pet dog ownership is way higher in white families, like almost like triple, I think, according to Pew. And in terms of the early life, like dietary environment is systematically different, across like different, socioeconomic groups, due to access, due to a lot of different factors, even the manner, like cultural differences in like typical manner of preparation of foods, where you might prepare foods like peanut in one way to render them more allergenic or less allergenic. I mean, they're all factors. So I think and I think with respect to early introduction, there's data from like the LEAP and the EAT study, which I thought I had in here somewhere, that showed very clearly that again, in LEAP and EAT in their British sample, they had very few non-white participants, but of those that they did enroll, they were sensitized earlier, than their kind of higher SES white counterparts. But if they got the intervention, they benefited even more. So it's not a matter of folks not being amenable to intervention. It's a matter of the interventions that are helpful not reaching the populations who need them most. And maybe the interventions not being sufficiently tailored so that they're taken up and promoted in the way that they need to be to really make a difference. And we've
Yeah.
actually looked at this ourselves, in these national data that we published a year ago, where we looked at, okay, what are parents doing? And if you're non-Hispanic white, you're much more likely to be introducing your kid to peanut, by 6 months, by 9 months, by 12 months. But it's not just the racial differences. It's if you look at income, it's the high income families, it's the more educated families. And it also is manifest in terms of what people are saying their physicians told them. So the good thing is when we ask them, what did your child's primary care doctors say to do about introducing peanut? They generally do what their doctor says. If they say feed at 4 months, they're going to feed around 4 months. They say feed at 6 months, they're going to feed around 6 months. But there's really systematic differences in the guidance that patients are receiving, or at least are reporting having received. And that's an area where it's very low hanging fruit
Right.
for intervention. Also around like perceptions of the effectiveness of early intervention, we saw very big differences across racial and ethnic and socioeconomic gradients of how much do you actually think that feeding peanut is going to prevent allergies? Like, do you think it's safe to do it at this age? And if you say no, then why are you going to do it?
Well,
And there's a role for education